Hello, everyone, and welcome. Thank you for joining us today. This is the second event in our series, IPC Practices in Addressing Wound Care. My name is Alyssa Longi. I'm Fort Peck, Assiniboine. My tribe is located in northeastern Montana. However, I'm located right now in Seattle, Washington. I'm a program manager at NCUIH, and I'm also a registered nurse. And so, as I mentioned, we'll be diving in and talking about wound care. We're really excited. We have a CDC SME with us today, Bola, and she will give a nice presentation around wound care, and then we'll also talk a little bit about the Rash microlens. Next slide. So just as a reminder, this session will be recorded. We ask that you mute yourself when you're not speaking. If you can, come off camera. If not, no worries. And then if you have any questions, you can always put them in the chat, and we'll have my colleague Zoe here who will be able to answer any questions for you. This is just an overview of what today will look like, the objectives, and then hopefully, as you know, this event is eligible for CEUs for nurses. And so at the end of the session, this QR code will pop up again. And what you'll need to do is just scan it. There'll also be a link in the chat. And so you'll do the survey, and then you can get your CEUs. And for those who aren't CEU eligible, you can get a certificate of completion through completing the survey as well. So just a quick background on NCUIH. NCUIH is a national representative advocating for the 41 urban Indian organizations, contracting with the Indian Health Service under the Indian Healthcare Improvement Act. Next slide. The National Council of Urban Indian Health recognizes its presence and work within a larger framework of historical and contemporary relationships with tribes and communities. NCUIH acknowledges that our national office in DC and nearby activities are situated on the traditional homelands of many Native nations. Some of the communities in the surrounding area include the Piscataway, Pamunkey, Nontego, Mattaponi, Chickahominy, Monacan, and the Powhatan peoples. These lands have deep historical, cultural, and spiritual significance to Native peoples. I also want to give a brief acknowledgement to Project Firstline. NCUIH is a proud partner of Project Firstline, as supported through our cooperative agreement. The CDC is an agency within the Department of Health and Human Services, and the contents of this program do not necessarily represent the policies of CDC or HHS and should not be considered an endorsement by the federal government. This activity is also jointly provided by NCUIH and Cardia Services. Next slide. And then this is just some of the information on how to access your CEUs. There'll be one contact hour that will be awarded. You have to attend the entire event and complete the online evaluation. And if you have any questions about that, you can always contact the name of the person here, or you can always contact me. And there are no relevant financial relationships with ineligible companies for those involved, with the ability to control the content of this activity. All right, so now we've got some of the housekeeping out of the way, we can move on to the main content of the presentation. As I mentioned, we're going to be hearing from Bola Ogundimu. She's a nurse infection preventionist, and I'll give you a little bit more about her in the next slide. All right, so Dr. Bola is a nurse infection preventionist and health scientist at the CDC's National Center for Emerging and Zoonotic Infectious Diseases within the prevention and response branch, and a part of the long-term care team. In Dr. Ogundimu's role, she provides consultation and technical assistance for implementing infection prevention and control strategies in long-term care settings in collaboration with state and local health departments across the US. I got a brief snapshot look at the presentation, and I'm really excited. So Bola, I will hand it over to you.
All right. Thank you so much, Alyssa. Can everybody hear me? I'm gonna go ahead and turn off my camera because sometimes we have crazy interactions with Wi-Fi. So I know that I'll be able to make it through this presentation with no interruptions, I promise y'all. So next slide, please. So again, I have no disclosures, no conflicts of interest for this presentation, and the content of this presentation reflect my own personal opinions and do not necessarily reflect the official position of the CDC. So next slide, please. So I'm going to be talking a lot about wound care today. So you guys would know how to spell it out by the time I'm done with different roles of wounds, as well as wound infection versus colonization or germ carriage, skin of healthcare personnel, etc. And then you'll also hear about common examples of like wounds, as well as a description of wound care activities that are common that we come across. And I think the crux of this presentation really is just really highlighting for infection prevention and control practices, as well as recommendations that we are consistently advising healthcare facilities and our health departments adhering to with wound care. And then again, we do have resources to address those recommendations. Next slide, please. So I've often wondered, like, what's the big deal with wounds among both skin infections? And so we've done multiple look backs at different studies over the years. And this is really connecting to, the CDC microlearn, as you guys are aware, that focuses on wound care. So we note that draining wounds can be caused by certain germs that can spread easily. They actually can contain germs that can spread easily, like our multi-drug resistant organisms, as well as non-multi-drug resistant organisms like DrPH strep, which I'll talk about in the next couple of slides. Again, it's important to note that there are times when we have germs essentially like living within our wounds. And so it's important to have those germs contained meaning not passed over, not spread to anybody else who comes in contact with the wounds. I've often asked, well, okay, so that's the what. You guys will learn about the how. Do you keep germs from spreading from wound surfaces or inside wounds, either between patients or actually between healthcare workers and patients as well. And we'll get into that a little bit more. So this particular study, this is a couple of years back, it was a retrospective study that looked at 12 different nursing homes in the Denver metropolitan area. And they looked at different sorts of characteristics or features of their residents. This is in a skilled nursing home within a 1-year period. They found consistently that there were a number of the most common infections that were present in the patients or the residents at the facility. The most common so they looked at 100 residents at the facility. And out of those 100 residents, there were about 55 of them that had cellulitis or essentially not oozing wounds at the facility. There was about a quarter of those residents also had non-oozing wounds. And then the other fraction of residents had like infected ulcer, pressure ulcers or abscesses in that facility. The interesting thing is we see all these wound infections, but in looking back at what the study was evaluating, it was noted that antibiotics were started right away for almost every single resident at the facility, but it was only in a quarter of residents that the healthcare provider actually ended up culturing to see, well, what's the need for these antibiotics. I'll get into that in a few minutes, but again, yes, we recognize that wound infections or skin infections are pretty common in our facilities. We also recognize that antibiotic stewardship may not necessarily be commonplace So there is that inherent increase in multi-drug resistant organisms at our facilities as a result. Next slide, please. Another part of wound care that we've actually looked at over the years is in terms of biofilm formation. And so there was a clinical study that looked back at what really wound care represented, as well as biofilms, which is the layer of could be bacterial nets on the surface of a wound. It's typically right around a wound, and it contributes to wound healing in a lot of places, or in some instances, non-wound healing circumstances. So evidence has shown consistently that biofilm plays a significant role in the inability of chronic wounds to heal quickly. And we recognize that in this particular study, like 90% of chronic wounds have had biofilm formation, which is like that top layer on top of the chronic wounds at any given time. What's important and interesting about biofilms is that it may represent that layer of film that forms over wounds that may prevent the wound from healing quickly. The other part is that it may prevent antibiotic treatments from penetrating where they need to penetrate for maximum drug efficiency in helping those wounds heal. You guys will learn the importance of this in the next couple of slides. So next slide, please. So we've talked previously about multi-drug resistant organisms and the role in wound care. And then also we have looked over the years at multiple studies that show that wounds and pressure ulcers are often associated with what we call acquisition, which is someone taking up a germ or picking up a germ. And when you pick up a germ, you could either be infected, where you have the classic signs of an infection with the fever, pus, etc. And then you could, if you're not infected, you could become colonized with the germ, which means you're carrying the germ around. Well, sometimes that's not so bad. However, if you're carrying a germ around, you could spread it to other people. This is across facilities. So if I always use myself as an example, so Ebola is carrying MRSA and I'm colonized with MRSA. If I'm at a healthcare facility A, I could very easily spread it to really anybody that comes in contact with me at this facility. So again, we've seen across multiple studies that wounds as well as pressure ulcers are often associated with acquisition as well as colonization of multi-drug resistant organisms, as I started to get into earlier. Next slide, please. So again, looking at the care of residents with chronic wounds, as I described earlier, multiple studies have also shown that in care of residents with chronic wounds, there is increased contamination of both hands and clothes. So think about it. Depending on whether or not you have that patient that you're taking care of that is totally or partially dependent on the healthcare worker, you will be in direct contact and close contact with that patient. And so there is the need to pay attention to what you're touching around that resident or patient, because you need to take care of them. But then it's also important to have the healthcare worker be appropriately dressed, have the personal protective equipment worn, as well as perform hand hygiene and multiple infection prevention and control strategies that would need to be implemented when folks are taking care of patients with wounds. Next slide, please. So I talked about, next one. Sorry, it's a clickable slide. So I talked about wounds a lot the previous the previous slides. And so it's important to understand some common examples of wounds that we see, right? So as mentioned earlier in the CDC microlearn that I talked about earlier, draining wounds, again, can contain germs that can spread by touch. So like MRSA, multi-drug resistant organism, which is methicillin resistant Staph aureus. And group A strep, which is another germ that I'll talk about in the later slides. These germs can be passed on from one person to another. And again, some common examples of wounds for management in healthcare settings include pressure ulcers, as I talked about earlier, as well as diabetic ulcers. So we have diabetic foot ulcers or ulcer vascular disease, so including peripheral arterial disease, as well as venous insufficiency ulcers, typically leading to lower extremity wounds. So again, it is critical to understand, yes, we have these wound types, but what do we do to prevent folks from getting sicker with the wounds? So next slide, please. So with the activities that we do with different wounds, those activities could include simple dressing changes or complex dressing changes like wound vac, which is a negative pressure wound management system. And that's complex as it is. There is also times when there is irrigation or and debridements of wounds. Again, if you look at these wound care activities, they go from simple wound care activities that I mentioned earlier to the complicated, complex wound care activities. One thing that we are continuing to see is that wound care services or wound care strategies are typically performed by in-house staff a lot of times. Sometimes they are performed by external staff or your PRN wound care nurses or wound care physicians who come in the facility once a week or every other week to do wound care assessments, where typically the bedside nurse may be the one who is managing the wound while the consultants are not there. Again, the same infection prevention and control strategies that your in-house person does should also consistently be done by the external consultants if your facility uses external consultants. So next slide, please. So we learned earlier that wounds can serve as reservoirs for pathogens or germs that spread in facilities due to lapses in infection prevention and control practices, or what we call infection prevention and control opportunities. So some of those ways include failure to clean hands at the right times, and also improper selection and use of personal protective equipment. Also, improper use of medications like creams, ointments, sprays, we've seen a lot of times. And in addition, failure to clean and disinfect or sterilize shared wound care equipment is also, we found, has been outliers for our outbreak investigations. The other two are just failure to clean or failure to separate clean from dirty supplies or equipment is also a factor. And then, having folks be reminded that staff need to wear their PPE accordingly. So if you're doing a debridement, for instance, and you expect to get splashed in the face, you might want to put on additional. So other than gown and gloves, definitely face mask, but perhaps a face shield, or you could just do a face shield to protect yourself and your face from getting splashed during those debridement activities. So next slide, please. So again, I think I talked about them earlier. Next slide. Oh, sorry, previous, right there, sorry. So I talked about earlier the hand hygiene and personal protective equipment opportunities. And I think I highlighted that in the previous slide. One thing that we're starting to highlight again is PPE is absolutely necessary to protect our staff and essentially protect the patients when we come in contact with their bodily fluids. That's just being the precautions. So the other thing that we're starting to highlight again is a lot of facilities may not necessarily have, they may have access to PPE, which is personal protective equipment, as well as hand hygiene supplies. One thing that we're noting, though, is that availability is also critical. So while you might have a storage room with the PPE as well as hand hygiene supplies, the isolation cart or the isolation caddy by a specific patient's room or close to a patient's room, sometimes we are finding that that caddy may be empty, does not have those supplies. So the facility may have the PPE as well as sanitizers in-house, but nobody is stocking them. So something to note is, again, as being part of our really culture of patient safety is to have everybody on board. So perhaps consider if you're doing like a shift huddle, for instance, having everybody double check, do we have enough PPE? Do we have enough hand sanitizers? What are we out of? Do we have enough EPA registered disinfectants, for instance? Again, we have found that sometimes we have the supplies in-house, but they're not necessarily at the point of use that is absolutely necessary. Other opportunities that we've identified in outbreak investigations have had to do with cross-contamination of wound care supplies. So again, inconsistent cleaning and disinfection of shared wound care equipment, as well as not communicating with the standardized, and each facility standardizes in their policies and procedures what the wound care equipment needs to be cleaned and disinfected with, who cleans what, when, where. Essentially, that needs to be communicated in the facility. One other thing that we have also found is that there are facilities that have healthcare workers carrying wound care supplies in their scrubs pockets or in their lab coat pockets. We continue to encourage folks to not do that, to find a clean surface for storing these supplies, not in our pockets, because we don't know what else has been in pockets, even if our uniforms or our scrubs were just laundered. It's just, it avoids the cross-contamination with whatever is in our pocket or was previously in our pocket, essentially. So if there's a clean supply cart, that's where the wound care supplies need to be stored. In addition, the wound care supply cart itself needs to be cleaned and disinfected. We suggest by a designated person, so whether it's your wound care nurse or your bedside nurse doing the cleaning, but that cleaning process needs to be communicated so that everybody is on the same page. One other thing that we found is opportunities for using multi-dose wound care medications. We always say that staff should really look at the package insert for the wound care medication. So if you have a wound care spray, does it say that it's multi-use? Or does it say that it's only a single use, like it's only for like a single person? And sometimes like it will say it's multi-dose. It will say on the package insert, please dedicate to a single resident, even though it's multi-dose, which is totally fine. We just continue to reiterate that in that case, if it's a multi-dose, container or tube or like an antibiotic like ointment should be stored separate from like the patient's area. So that container itself should not be brought into the patient's room. It should remain like in the medication cart. And we've suggested that folks like find a medication cup for squirting that the allotted, like if it's like 5 milliliters that needs to be allotted for one dose, that needs to be squirted into the medication cup, for example. Next slide, please. So I went over hand hygiene as well as PPE selection, as well as the next slide, environmental cleaning and disinfection, as well as cleaning and disinfecting reusable medical equipment, things like banded scissors. We often say that there are some facilities that don't necessarily have that single bandage scissors for every single patient that is getting wound care. What we do say is that we recommend that the bandage scissors or any other wound care equipment needs to be cleaned and disinfected according to what the manufacturer says in their instruction for use. Usually it's a pamphlet or a brochure that comes with the package itself. So staff need to follow instructions that are indicated under instruction for use. And then also once clean, those items like the bandage scissors, for instance, should be transported and stored again in a clean, non-contaminated area. So not the pocket, but things like a clean cart. But just make sure that the bandage scissors doesn't make it to like the next patient, if it's a shared room, doesn't make it to the next patient's like bedside table so that it's not contaminated in the meantime. Ideally, we say that things like bandage scissors should be dedicated to each patient who is getting that wound care done. Next slide, please. And next slide. Next slide. Sorry. Thank you. All right, I think I already went over that. So next slide, please. All right. So again, I talked about wound care supplies, whether it's your bandage scissors, again, gauze and tape. One thing that we continue to reiterate is the need for staff to gather supplies before they go in to get their wound care done. So essentially, I always use myself as an example. Bola has a sacral decubitus stage 4, and she needs a wound vac replacement or change or dressing change. If Nurse Abby is going in to help Bola with her wound vac dressing change, we would expect Nurse Abby to go in to Bola's room with all the items that she would need for that wound care dressing change instance, so that she's not going in and out of the room. What we've sometimes seen is folks go in the room with some supplies, say they need 15 supplies for that wound care dressing change, but they only go in with 5. Well, inadvertently, they're gonna have to go back out and get the other supplies. And so we've seen in instances where this happens, folks going in and out of the room multiple times. The downside of having to go in and out is that you have to take off your gown, do your hand hygiene, go get the supply, come back and don your glove. Is it your gown and glove again? Well, do your hand hygiene again and don your gown and glove again. So because of the multiple steps and maybe a little bit of a hassle with not getting all the supplies together in the first instance, there are more instances of cross-contamination in those situations. So again, I talked about additional like external wound care consultants. While they're filling staffing vacancies, they need to be aware of the facility essentially. So next slide. So I have, oh, sorry, next slide, please. Yes, okay. So I have a quick question for everybody, as I like to ask questions. Just curious, based on everything that I've said so far, and please, if you guys can please type it in chat on what you think the right responses are. So the polling question is, which practices should the healthcare personnel or staff follow to prevent germ or pathogen transmission? The first option is, should they store supplies on a clean cart and bring the cart into patients' rooms as needed? That's option number one. Option number two is, should they dedicate multi-dose topical medications to a single patient whenever possible? Option number three is, should they return unused disposable supplies that entered a patient's room to the clean supply cart for future use? I mean, the clean supply cart is in the hallway, so is that right? And then the fourth option is for the staff to select and gather necessary wound care supplies for use in a patient prior to entering the room. So I will pause for a minute just to see where you guys are. Just so is it the first option, which is store supplies in a clean cart and then bring the cart inside the patient's room? Second option is dedicate multi-use topical medications to a single patient whenever possible. Third option is return unused disposable supplies that entered a patient's room to the clean supply cart for future use, especially since it's in the hallway, which is the cart. And then the fourth option is to select and gather necessary wound care supplies for use in the patient prior to entering their room. So I'm not sure if folks are putting, oh, okay, I see it now. So if we can continue just to type it in, love the interaction, absolutely. Yes, so yeah, if we can continue to just type in what we are thinking so that we know where everybody is, and we can move on to like, well, actually, while we're in this section. So the right answer, I see some of you are pretty right. So the right answer is options B and D, which is again to dedicate multi-dose topical medications to a single patient whenever possible, as I illustrated earlier, as well as select and gather necessary wound care supplies for use in a resident's room prior to entering the room. Again, I talked about it earlier, gather supplies before you enter the room, so you're not going back and forth and recontaminating everything. And you should not be putting the clean cart inside the patient's room under any circumstance. And then also unused disposable supplies that have already entered the patient's room should not be returned to the clean supply cart, because that's contamination right there. So great job, everybody. Y'all did a pretty good job. All right, so next slide, please. So I started to get to this example earlier. This is, thanks, Alyssa. So this is group A strep. And the reason why we talk about this, within the CDC a lot is because we have to investigate a wide number of outbreaks going on across facilities in the US. And not just for group A strep, but also for other germs. But I'm just going to pick group A strep for this example. Next slide, please. So this is just an example of a group A strep outbreak investigation that actually in this particular long-term care facility ended up causing quite a number of invasive, what we call invasive infections, like bloodstream infections and sepsis in some cases, as well as pneumonia. So we recognize that group A strep could cause quite a number of serious life-threatening infections, especially in frail older adults. So that's just point to note. Next slide, please. Exposure to group A strep, as I started to talk about, may lead to carriage or infection. And I think earlier I talked about carriage, meaning someone has it on their skin surface or on their throat. They definitely won't know that they have it because they don't have any signs or symptoms of an infection, but they could pass it on to other people in the process. If you click next. So a lot of times we do recognize that group A strep, this particular organism or germ, is present in the throat or skin without any signs or symptoms, and in a lot of our population. So it's in about 20% of children that are around, like, for example, in our school system, could be carrying group A strep in their throat. And then about 5% of healthy adults, not older adults, healthy adults could also be carrying group A strep. It's important to recognize that carriers can transmit group A strep. And so we have it in multiple forms. So when carriers end up developing an infection over time, there are different forms of infection. So there is the non-invasive infection, which we see in pharyngitis, or what we often call strep throat. And then there is the invasive infection that, as I started to talk about earlier, like septic shock or cellulitis or flesh-eating, just to call it flesh-eating bacteria, or necrotizing fasciitis. And, again, while this doesn't happen a lot of times, it happens in the US about there are about 20 to 27,000 invasive group A strep cases every year. Next slide, please. So it's pretty serious. So again, I picked this organism because it's important, because humans are the only reservoir, which means it only lives in humans. It's not in animals, it's just humans. And so it's typically passed on from one person to another through respiratory droplets from either an infected or colonized person to anybody, just I call it like a bystander, to anybody who happens to be around that person. But then we also recognize that skin-to-skin contact with lesions or wounds of infected persons could be another way that it's transmitted to other people. There hasn't been a lot of research on environmental transmission on surfaces or even fomites, but even the limited evidence that's available suggests that it's not typical, like it's uncommon to have it transmitted or stay on a surface for too long so that somebody else can pick it up on that surface. Next slide, please. So again, this is just highlighting group A strep infection in long-term care facilities, and specifically in these types of facilities. And we found not just long-term care facilities, in healthcare facilities, risk factors for group A strep infection or carriage or colonization, as well as exposure to a healthcare personnel with pharyngitis or strep throat. And then also, particularly for patients that need total care, that are, for instance, like our term Q2 patients who are bedbound, that are heavily dependent on healthcare workers for movements or any activities of daily living. they could be at risk for spreading it within the healthcare facility. And also anybody getting any form of wound care. Next slide, please. Next slide. So again, we talked about group A strep transmission, just as an example. Respiratory droplets or direct contact with infected secretions or lesions, or colonized secretions or lesions. And again, we talked about asymptomatic colonized staph that work pretty closely with wounds. Could be another way that it's transmitted from one person to another. Again, the human is the reservoir. It's not transmitted across animals right now that we know of, but it is transmitted from one human being to another. So I will bring up the next slide, please. Next slide. So I got another question, as y'all always know. I always have questions. So this one is just another one. So it says, what are some potential routes of spread for group A strep during wound care? Number one is taking Tylenol before clocking in to your job. Once, this is Bola. Again, I use myself as an example. Once Bola, strep throat, or pharyngitis has, subsided, like my fever has subsided, so I could take Tylenol and just go with it. Is that one option? Number two is asymptomatic colonized staph interacting closely with wounds. That's the second option. Third option is consistent use of personal protective equipment like gowns, gloves, face masks, etc. during wound care in the context of a group A strep outbreak at the facility. The fourth option is shared Band-Aid scissors and wound care items stored in Bola's pockets between residents. So which one is the right one? All right. So I see y'all answering, and thank you so much for answering. So in the interest of time, I will get on to the right answer. So the right answers in this circumstance is, again, for potential routes of spread for group A strep during wound care, they would be, yes, me, taking Tylenol before clocking in because I have strep throat, but I'm just, likely trying to wing it to show up to work sick, essentially, which is what we call presenteeism. Folks should not be working while sick, febrile, pharyngitis, etc. We typically say, for folks that are affected by specifically group A strep, they should be on antibiotics at least the first day for at least 24 hours before showing up to work. And they should be showing up to work febrile anyway. And then the other thing is that asymptomatic colonized staph, absolutely, because we have to be in close proximity to the wound itself. So if your face is all over the wound, well, guess what else is breathing on that wound? So if you're colonized with group A strep, you just passed something on. And then one last thing is just share Band-Aid scissors. We already talked about that. All right, so next slide, please. Again, as I started to illustrate earlier, it's important to understand and communicate infection prevention and control practices specifically related to wound care at your facility. So next slide, knowing who's doing what when, having specific policies and procedures, next slide please, that address wound care is critical to any facility. Next slide. Next slide. And again, we talked about wound care supplies storage. It is important to ensure that clean supplies are totally separated from dirty supplies. So some folks have Clean supplies are stored in clear plastic bags so that it's obvious to anybody that these are clean supplies. So have your healthcare facility have a designated and communicated system for storing clean versus dirty supplies. Next slide, please. Next slide, please. Trying to get to next slide, please. Next slide. And next slide. Okay, I already talked about next slide, please. And then one more slide. Next slide. Okay, right there. So remember, in nursing school, I was always told this: if it's not written BOLA and it's not documented, it wasn't done. And I still remember that till to date. If you didn't document it, you didn't do it, right? So you can't assume everybody knows, what you're thinking. So unless it's documented, again, continue to highlight to staff to really document what's done, essentially in a way of communicating what staff need to be doing. So with that said, we have a whole bunch of resources that are available at the end of this presentation. Please feel free to chime in, and I love all your participation in the exercises that we did. And I think I will end with that 2 minutes post. Sorry.
No worries, Bola. That was wonderful. I was really into the presentation too. So I'm definitely like a pocket stuffer. It's hard when you're like on the go and you're like, oh, okay, I'll just put everything here and then go there. So that's a good. So just so you know, Bola's contact information is here. I can also share that in the follow-up email in case you want to reach out to her. Okay, so I wanted to touch briefly on wound care and considerations around the American Indian and Alaska Native population. So I just have one slide here. Bola talked a little bit about diabetes, but I'm sure as most of you here know, American Indian Alaska Natives are disproportionately affected by diabetes, and adults are almost 3 times more likely than non-Hispanic white adults to be diagnosed with diabetes. And that diabetes can delay wound healing due to poor circulation, damaged blood vessels, and weakened immune system. So you may have a client who comes in who is experiencing numbness in their feet due to diabetic neuropathy. And for these clients, diabetic foot ulcers can occur, and that can result in open wounds, which are slow to heal. That's just something to be aware of. They may be visiting you for something else other than even their diabetes management, but that's something that in the UIO setting you may encounter. And then I wanted to just also touch on substance or injection drug use as another point of consideration. Injection drug use or persons who inject drugs isn't well documented in the American Indian Alaska Native population. I think we all know that a lot of stuff isn't well documented and there's a lack of research, but this population is documented to have higher rates of substance use compared to the general population. I do want to acknowledge that there are many factors that contribute to that, and these are just a few, but historical trauma, violence, and sexual abuse. I think it's important to keep that in mind when we think about persons who inject drugs. But regarding wound care, repeated injections at a single site can damage the skin and the surrounding tissue and skin and soft tissue, so infections can be common. Can be a common complication of injecting recreational drugs. And so that's just another thing to keep in mind. You may be at your facility, you might be out in the field, and you have somebody who comes up to you who wants to get a vaccine, and you notice a wound somewhere on their arm. And so being aware of that, especially when you when thinking of protecting yourself and wearing PPE, even if it's something that you may not normally use PPE for. Okay. To the next slide. And then so the microlearn, this is the Rash one. I just wanted to let you all know that these are also available in Spanish. So if you have staff who are primarily Spanish speaking or who prefer Spanish as their language, they also have these job aids. And then the description of it in Spanish as well. And I just have to give a shout out to our Project Firstline partners from South America who helped make that happen. And then this resource I'll go over really quickly is just a new graphic that we have. So if your facility does transportation and you're not really sure what you should be doing around infection control, this graphic is a great guide. It has a visual component to it, but also a written component that you can go through and check off, print it, laminate it. And Zoe will put a link to that in the chat. But just different considerations that you should have when you're transporting clients. All right, next slide. And then this is a new video that we released. I won't show it here just so that we have time to ask questions, but it's about a 1-minute video that goes over cleaning and disinfection at a UIO facility, and then those different points where it's important to remember. So Zoe will put this in the chat. This is something that you could share with your staff via email. You could show it at an all-staff meeting, but it's just sort of that nice reminder to clean and disinfect. All right, next slide. And then these are also just a few other reminders of different materials that we have available. We have other graphics and we have another video. Here are a few of our upcoming events. And then, oh, if you can go back one, River, I think the open floor slide skipped. That's okay. So I did want to open up the floor to see if anybody had any questions for Bola related to the presentation. We do have some time left. You can come off mute, you can put them in the chat. You can also direct message them to myself or Zoe and we can ask for you. And so I'll pause here. Put a little bit of awkward silence there, see if anybody has any questions. So what infection prevention and control gaps are you seeing with wound care? I think Bola's asking you all that. And yes, slides will be sent after. It looks like here's a question. My UIO is currently working on updating our policies and procedures around wound and rash care. Can you recommend any places that have good examples that we could draw from? And Bola, the question is also
yeah. Yeah. Oh, I was starting to type, but I typed slow. I apologize. So we do have our, it's free, right? Free stuff is always good. We do have our infection prevention and control training. It's the nursing home infection prevention and control training. And I can send that link to Alyssa. And so there's a specific, so it's 23 modules, 23 different chapters. It's online, it's totally free. You can take your time in taking if you want the 23 chapters, or you can take one chapter. One chapter is specifically dedicated to wound care. And we have like a sample policy on just PPE focused as well as hand hygiene focused. If you guys are interested, we've had people like download the policy and like customize it so that they can use it at their facilities. But yeah.
I know exactly what training she's talking about, and I definitely recommend it. Yeah, you can pick and choose. I'll actually share. I don't have the actual wound care one, but I have the hand hygiene one. So I don't know if it'll send in the chat, but just to give you like a sneak peek of what she's talking about, it's really great. It even talks about how to write policies and procedures, because as we know at UIOs, many people wear many hats. And so if you're the one who's actually responsible for writing policies and procedures and you're like me and you never had training doing it, this training actually covers a module on that as well. And there's another question. What should I do if I'm out in the field, for example, at a powwow, and I do not have all the necessary resources to clean the wound? That's a great question.
Oh, sorry. And what like necessary resources like your scissors, your ointment, your sprays.
What I'm thinking they might mean is, for example, sometimes they'll have like a vaccine tent or something, and what I'm just thinking is if someone comes up and they may not even be there for wound care, but they notice the wound, what could you do? Or if they are doing, I guess, a wound care tent and you have somebody who comes up and you don't have supplies.
Yeah, and I think I wonder if you could, like I would imagine, even if you have like 4x4, 2x2, if those are your limited supplies and maybe the saline spray, right? Try to squirt if it's like a saline, typically they're like 10 milliliter like bottles with the spray nozzles. You can spray it into like the medication cup. So that's that allotment for that specific patient. And then, if you can find like the gauze dressing, not necessarily Tegaderm, because depending on what facility you're at, you may not have that accessible. But again, just using essentially what you have, right, to cover the wound. So if it's a 4x4, 2x2 that you have, you know, if you're lucky, you might be able to get like a Curlex to like wrap the wound if needed. But again, just yes, using the supplies that you have, but keeping in mind that supplies typically should not be shared across patients, right? So if you have very limited supplies, that's understandable, but maybe perhaps like try to use the limited supplies in isolation, quote unquote, for that specific patient, one patient at a time. So if you only got like the rolling bandage, cut out the band-aids that's only needed for that patient. Don't take the whole roll with you, because then you're going to be contaminating the roll if you bring it by the patient's bedside.
I love that you bring that up because that's another thing where I'm notorious. I'll like, okay, I'll just grab a bunch of supplies, bring them in, but it's not open, so it's fine. About the resources and everything and not wasting. And so I'm glad you brought that one up too. So it's good reminders. When we're moving so fast, like what's the shortcut I can go? Some of them are just not ones that we can do. Well, are there any questions? I want to make sure we have time to get the QR code. That way those who are here can get their certificate of completion. All right, perfect. So there are references, which we'll have those on the slides that we send out hopefully by the end of the week. But thank you everyone again for joining us. Thank you so much, Bola. That was really interesting. I don't think we've covered wound care here at NCUIH, and so I was really excited for this presentation. For the CEUs, as I mentioned, they're CNEs, so nursing ones that we're offering today. You can scan this QR code, which will take you to the link, the survey, or you can also click the link in the chat that we shared.